everybody. It's my privilege to be amongst you all again, and I'll be talking about the LH. Now we know that FSH and LH both are very important as far as the female reproduction and the male reproduction is concerned. For that, we need to have an intact hypothalamo-pituitary ovarian axis. Now, initially the FSH will be secreted by the anterior pituitary, and it will cause a maturation of the follicle. And once the follicle is mature and producing enough amount of estrogen, by the feedback, it will cause the release of LH, which helps in final maturation and the ovulation process which takes place. Now, the few points which are important about the LH is that its half-life is 38 to 60 minutes only. And LH role in folliculogenesis, though known to some extent, is still not very clear. We know that it induces follicular maturation and the sequence of events leading to the ovulation. But in the initial phases of folliculogenesis, what exactly it does, we do not know. So we'll be trying to understand that. And finally, it acts upon the thicker cells to formation of the steroids, basically the progesterone, for continuation of pregnancy. We know about two hormone therapy. There are thicker cells and the granulosa cells, which are separated by a small membrane. So with the result, there is no direct vascular connection with the granulosa cells. It is only by the, you can say, osmosis, the whatever has to go from the thicker cells to the granular cells, it will go by the concentration gradient. Now the thicker cells have, in the early phases, the LH receptors, and the granulosa cells have the FSH receptors. The LH, which is being secreted in a smaller amount, will be acting on the thicker cell cholesterol conversion to the androgen, which then reaches into or goes into the granulosa cells, and by the aromatase gets converted into the estrogen, which produces an estrogenized environment for the follicle and the OCC to grow naturally. In the late follicular phase, the LH receptors are also manifested on the granulosa cells. So at that stage, in the thicker cell, the LH would help in the steroidogenesis, while in the granulosa cell, firstly the LH causes the up-regulation of the FSH receptors. And bigger the follicle, the more mature the follicle, the better it will be affected by the LH rejuvenation or reformation or upregulation of the FSH receptors. And in nature, the smaller antral follicles, the follicles, do not have that much of FSH receptors, so they would be suppressed by this LH, while the bigger ones will be helped by this LH receptor to develop more FSH, so that we can get one dominant follicle. So with LH and FSH, causes sustained follicular growth of the dominant follicle and causes final follicular maturation, which involves not only the cytoplasmic, also the nuclear maturation of the oocyte. Now LH, it required at certain values. When the values are high, then you find there is a follicular atresia, there is a premature luteinization, and also the oocyte development is compromised. And this happens when the living example of this is the PCO patients, where the LH is high and they form the follicles up to a certain stage, and then those follicles go into atresia, and you do not get a mature follicle in these patients. And the other extreme, when the LH is very low, it would affect the estrogen synthesis, it will impair the follicular maturation, and because estrogen is not there, there will be inadequate endometrial proliferation. This happens in the cases of hypogonadism, whether it is natural or iatrogenic, created by giving down regulation for a longer time. When it is in the adequate amount, which is a LH window, it will cause adequate androgen formation, which would get converted into estrogen by biosynthesis, and the normal follicular development and oocyte maturation is possible. So there is a small range which I'll be talking about of the LH values, which are important for having a estrogenic environment, helping the oocyte maturation and development. So ovarian follicles have a developmental related requirements for the stimulation by LH. So that means in the initial stage, they do not require LH. It is only when they have grown beyond certain size, so then only they would require the LH, because by the time the LH receptors would have also present in the granular cells. Now, if the LH is beyond a certain ceiling level, that is when it is high, it would suppress the granulosa proliferation and initiate atresia, premature luteinization, as I mentioned, which happens in the PCO patients. However, the mature follicles, they are resistant to this higher ceiling of the LH rather than the immature ones. So this helps in getting a dominant follicle in a natural cycle. And this same theory, you can use it when you have a PCO patients having a irregular crop. There are bigger follicles and there are smaller follicles. Now, if you keep on stimulating this patient with the FSH only, even the smaller follicles will grow, and the number of follicles which you will be puncturing will be very high, causing the chances of OHSS. But if you add LH at that time, the smaller follicles will get suppressed. It is only the bigger follicles which will grow. So with the result, this is another strategy to decrease the chances of OHSS by adding the LH in the second phase of stimulation of the IVF cycle. So during ovulation induction, LH dose should not exceed the ceiling of the most mature follicles. Otherwise, those mature follicles will also start going into atresia. Sometimes you find that the follicles have grown on day 7 or day 8, and then subsequently they don't grow. And if you try to give very high dose of LH, it won't help. Some amount of addition would help, but high dose of LH at that time would cause atresia of even these would-be mature follicles. So today we'll try to understand the role of LH in reproductive cycles in detail. We will identify the patient subgroups to whom LH supplementation is beneficial. And lastly, we'll try to understand the differences in the LH supplementation according to the gonadotrophin preparation. By that, what I mean is whether we are taking it through the HNG or we are adding the recombinant LH. So what is the difference between the two? So the first question is LH important in reproductive cycles? Answer could be absolutely true, maybe true, or false. Let us see what is the correct answer. Now, this is the case of hyperhypergonadism, where the patient is being stimulated with FSH, and then there is a step-up regime which they have used. And what you find that the follicles, they would not be seen initially around, say, 8 days or so. And then subsequently, if you keep on giving the FSH, the follicle will start growing. But however, the estradiol level would not grow commensurately. With the result, the endometrium would remain thin. So that means the FSH can grow the follicles, but the estrogenic environment will not be there. So with the result, not only the quality of the oocyte will be poor, even the endometrium will be also poor. But the European recombinant human LH study group, they studied what happens when we try to add LH to these patients in different doses. That means first is no LH, second is you just give 25 IU, 75 IU or 225 IU. So what they find is the up to 75 IU and 225 IU, there is an optimal growth of the estradiol levels in these patients. So beyond 75 levels, the estradiol levels are on the lower side. So the endometrium will also be lower. So what we need to understand is that we require something between 75 to 225 IU LH if we have to add to these patients of hyperhypergonadism. Now, the threshold is tried to be understood as far as the endometrial thickness is concerned. So here the patient has been given with 0 LH or 25 IU, the endometrial growth is poor. While when you add 75 or anything more than that, up to 225, you find you get a optimal endometrial thickness. So that means you require at least 75 IU to start the to get the good thickness of the endometrium. That means the estradiol level also will be commensurately okay for this patient. So what is the minimum requirement? So we saw that with 75 to 225, the endometrial growth was same. So the various authors tried to study what is the LH Cmax value in the blood when they give 75 IU. It was found the Cmax level was something between 0.5. That means the mean concentration was between 0.5 to 1.35 international units per liter when 75 IU was given to these patients. So with 75 IU, if you get the mean value 0.5, this you should remember international unit per liter is a minimum requirement of LH, which is important for getting a good follicular genesis. So that means LH is important in reproductive cycles. If you keep on giving only FSH, especially in hyperhypergonadism group of patients, then you may not get the good follicles and the endometrium will be poor. So it is required, but then do all the patients require it, or only the poor responders require it, or hypo responders require it, older patients require it, or the patients who are in antagonist or agonist protocol, they require it. Now this we have to understand. Do we need to give LH? In hypo, we know that we have to give it. But other patients, who are the other patients where it is required to be given? We'll try to understand that now. Now, if you see the normal cycle, you find that over a period of time, the LH is firstly at the bottom level. So by day 8 or so, it is around 3.1 international unit per liter. And then there is a LH surge, which is required for the rupture. But in cases of patients having GnRH agonist or antagonist, you find these are the levels which are attained. So even when the patient is downregulated, she would have some amount of LH, which is just sufficient for it to grow without adding extra LH from outside. While hypo would definitely be having lower than 0.5, which I mentioned earlier. You must remember that figure will be lower than that. So would definitely be requiring LH from the beginning only. So there was various, the studies which have shown that in the patients who are on stimulation with FSH and GnRH analog, that is your conventional protocol, and which was compared with the patients where they added the recombinant LH and they studied the live birth with no patient selection, they found that it was not essential. It did not improve the pregnancy rate, whether you gave only the FSH or you gave FSH and LH to these patients. So the point to remember is, even in the long protocol, that is a agonist protocol, there is some amount of LH is always present, which is just sufficient for the follicles to grow. you may not require LH to be added in this group of patients. Now, what about the antagonist protocol? Again, the Mosher et al. And Brophy et al., they studied about 8 RCTs, and they came to the conclusion that it did not improve the result when you added LH to the patients who are on stimulation with the antagonist protocol. Because even in the antagonist protocol, you will have some amount of basic LH, which is just sufficient for the initial folliculogenesis. Now, the comparison was done between the minotropin and highly purified HMG and the recombinant FSH in a ICSI cycle. The live birth rate was studied. So you look at these three. So with the HMG, that means which is not purified, the live birth rate is less. However, with the recombinant FSH alone or with the HMG, which is highly purified, the live birth rate was better. But the point to be seen is in the next part of the slide. Your number of days which is required in the cases of the recombinant FSH is much less. So it is more patient friendly. Number of injections would be less in comparison to the patient who are on highly purified HMG for stimulation. And the patients who are having normal urinary HMG would require more number of days and more units of the HMG in these patients. So where the FSH 6000 IU may be required for the full folliculogenesis, while in the urinary product it may be 9000. So almost increased by 52%. Requirement is there, more injections is there, and you all know that number of injections also affect the quality of the eggs. More the injections required, lesser is the quality of the oocyte. So the question was, who need the LH supplementation during ovarian stimulation? It is mandatory in hyperhypergonadism, we know that, because they do not have FSH, they do not have LH. So you need to give both to them. And but for most patients of IVF, endogenous LH levels, irrespective whether it is a GnRH analog or antagonist, is sufficient to suppress the follicular development and serogenic activity. So FSH only stimulation is enough in these patients. So as there is some amount of LH always present, even when they are downregulated, you need not add LH to this group of patients. But the problem is a group of patients who have a lesser bioactive LH levels. Now these patients, whether they are agonist or antagonist protocol, 70% of them, they will behave normally. But 30 to 45%, they have less sensitive ovaries. That means they require high dosages of FSH if you put them only on the FSH. And who are these patients? Who are older patients, more than 35 years, or those who are poor responders, or those who are slow or hyper responders, or those patients who are deeply suppressed by long protocol in cases of endometriosis. So this group of patients, they would behave differently as agonist or antagonist protocol, and let's see what happens to them. Now these patients, they possibly have a aged ovaries, and because of that, there's an impaired oocyte quality, there's a decreased fertilization rate, there's a reduced embryo quality, and there is an increased miscarriage rates. And this happens because the various hypotheses have been given because of the reduced ovarian paracrine activity, or androgen secretory capacity is reduced because we have not added the LH in these patients and the androgen is less. The decreased number of functional LH receptors in these patients, or because of the reduced LH bioactivity. So naturally, they are having some amount of LH, but since the bioactivity is less, so it is as good as no LH in these patients. So you may have to give longer duration of FS to these patients, or you add on LH. I'll come to that. So these patients, the forest plot studies for clinical pregnancy by various authors has shown that when the woman is more than 35 years, it is more favorable to add recombinant LH along with the recombinant FSH for getting a better quality of oocytes and better pregnancy rate. Now here, if you see, the age-wise, the women who are less than 35 years, and we are seeing the implantation rate for these patients. Now, whether you give them only FSH or you give FSH plus LH, the pregnancy rate remains the same. The implantation rate remains the same. But however, women who are more than 36 years, more than 35 years, or 36 and 39 years, you find if you give them only FSH, the implantation rate is just 18.9%, and when you add LH to them, then the implantation rate improves and it becomes 26.7%. So the pregnancy rates increases by 30% in poor responders when they are treated with the recombinant LH along with the FSH to them. So various studies are there which show that the patients who are poor responders, they will be benefited by adding the LH. And for every 1000 IU of the gonadotropin which is given the poor responders, when you add LH, you will get one extra oocyte. So earlier, if she was taking, say 3000 IU was required of FSH, so she got, say 2 eggs only, but now she may get 4 to 5 eggs if you add LH to these patients. So why is LH beneficial in these patients? Possibly it seems to be because of the androgen, because you find that as the woman age, the total testosterone level decreases by 55%, DHEAS level decreases by 77%, free testosterone level decreases by 49%, and androstenedione decreases by 64%. And because of LH, the action of LH at the follicle level, which is dose dependent, increases the androgen production. And these androgens then are aromatized to estrogen, which will restore the follicular milieu and cause a more better quality and more number of oocytes. The another important aspect of LH supplementation is LH also has the ovum pickup in a poor responder where you have stimulated it only with the FSH. You'll find that the OCC will be smaller in size because the granular cells which are coming with the OCC with the oocyte are lesser in number. While the patient who has been supplemented with LH, as an embryologist, you would see that the cumulus mass is much more along with the OCC, with the oocytes, because it does not allow the apoptosis of the granular cells. Secondly, it also helps in increasing the FSH receptors responsiveness. So the FSH receptors which are already present in the granular cells, which are required, for the folliculogenesis, they become more responsive to FSH under the influence of LH. LH also upregulates some growth factors in the follicular apparatus and also acts synergistically with the insulin-like growth factor 1. So all these things put together gives you not only more number of oocytes, but also the better quality of oocytes in this group of patients. So who need the LH supplementation during ovarian stimulation? So evidence shows that it's a beneficial effect in the older patients and poor responders. And benefit is related to the increased androgen production and also direct effect on the ovary for better follicular recruitment, high number of oocytes, and better implantation rate. Now, there is a subgroup of patients which are initially called poor responders. So these are the patients. Otherwise, they have a normal ovarian reserve. If you see the antral follicle count, it is normal. you stimulate them, the follicle grows adequately up to day 7 and day 10, and then you find the follicle growth stops after that. And even if you keep on increasing the dose of FSH, it does not, move further. And to achieve the adequate number of oocytes and estradiol production, you may have to increase the dose of recombinant FSH, which will be much more than 3000 IU requirement. And the duration of stimulation will also increase. And why this happens? The normal LH which is present in these patients, which are hyper-responders, which were not expected earlier, it is because of the LH gene polymorphism. Various ethnic groups have a different carrier frequency from 0 to 52%. And because of this, there is a reduced bioactivity of the LH. So if you do the blood test of LH, the LH naturally is present, but it is less biologically active because of this polymorphism. And when you see the FSH consumption in these various group of patients, those who are having homozygous polymorphism, they will require the highest number of injections of FSH, and then lesser in the case of heterozygous presence of carriers in the polymorphism, while the wild type would require a lesser type. So the most of your patients, the 70% of the patients are in this group, while about 30% of the patients are in this group. You see their antral count is okay, their AMH is all right. They respond very well up to day 5 to day 10, and then there is a stop growing. And these are the patients, if you keep them only on FSH, you require higher dose of FSH, more number of days of FSH, poor quality of oocytes. But if you add LH at that time, you find your requirement will be less, the number of days will be less, and the quality will be good. So these hyper responders would benefit as per this Cochrane review by adding LH to these patients after say day 7 to 8, you add LH, recombinant LH to them, so they would get benefited. So again, this RCT which shows that the mean number of oocytes retrieved, implantation rate, and the pregnancy rate would be much less if you are just stepping up the FSH and the follicles are not budging as they would grow otherwise, 2 millimeter per day. But when you add LH to this group of patients, then you find that the implantation rate is improving, the pregnancy rate is improving, and number of oocytes is also improving, and which becomes almost like a normal responder. So the third key point is that the evidence shows that the beneficial effect of LH responders, LH supplementation in the hyper responders, and which are initially grouped as the poor responders, and it is dose-related increased LH bioactivity with a positive effect on the androgen production and the ovarian function. So in a nutshell, finally we have come to the conclusion, LH's supplementation is required in the poor responders, in the older women, and also unexpected hyper responders. They would be the one would be benefited by giving LH, when all other patients or whether any other protocol, agonist or antagonist, would not require LH supplementation. Now, which product should we use to give LH to the patient? Whether HMG or highly purified HMG, or whether recombinant LH, or any of these, because they all have a similar effect. Now, when you see the HMG or highly purified HMG, you find that the injected proteins are higher. But when you give the recombinant LH, you find that the injected proteins are lesser. More the proteins, more the chances of antibody formation against them. So you'll find the patient who has already been stimulated 2 or 3 times for IUI or for IVF, And if you try to use a urinary HNG or highly purified HNG, you'll find that the response will not be as good because the patient has developed antibodies against these proteins. But if you add the recombinant LH to them, where the protein content is very less, you find that the response will be better. So basically, the source of LH is either SCG, which is a surrogate LH, or the original molecule, the recombinant LH. Now, what is the difference? It is the beta unit of the SCG, which acts as the LH, and it is longer in the cases of SCG in comparison to the LH. So with the result, they have a higher receptor affinity in the case of SCG. So that means if you give SCG also and LH also, more SCG will get attached to these receptors than the LH. And the second difference is the carboxyl terminal segment of these of the SCG is longer, and because of that, which is present in the SCG, which makes it a longer half-life. So that means if you give SCG, the chances of SCG means HNG, which is having actually they add SCG in that. I'll come to that, which will have a longer half-life. The chances of ovarian hyperstimulation is much more. But since this carboxyl terminal segment is absent in the LH, so the half-life is less. So with the result, the chances of ovarian hyperstimulation would be reduced if you add recombinant LH in comparison to HMG containing SCG as a surrogate LH. Though both these molecules would act on the, they get attached to the same receptors, which are expressed on the theca cells and the granular cells when the follicle size become 8 to 12 millimeter. So initially up to 8 to 12 millimeter of the granular cells, you will not find the LH receptors. Initially only on the theca cells, and then subsequently when the follicle is more than 8 to 12, on the granular cells also you find the LH receptors. Though LH and SCG both are acting on the same receptors, but the further actions are different. The downward cascade pathways are different. LH would increase the LH receptors as well as the FSH receptor expression. So that means the lesser dosages would help you to get better result. It also helps in meiosis and follicle maturation. So you require more M2 oocytes rather than GV and M1 oocytes. The follicle development is better, and the cellular growth, the granular cell will be better. And because of that, the estrogenic environment will be better. The ovarian steroidogenesis is better. And because of better quality of oocyte growing in a better estrogenic environment, the embryonic development and the survival of the embryo is better when you give LH. And opposite happens when you're giving surrogate LH in the form of SCG in the HNG injection. So you'll find these are decreased. So when you are, say, given FSH initially and then you give HNG, the possibility of getting more M1 and GV oocyte will be more rather than when you give recombinant LH along with the FSH in the second part of the stimulation. Secondly, LH would inhibit the aromatase inhibition. It decreases that, and also it decreases the apoptosis enhancement genes expression. So with the result, you have a more estrogenic environment, and the apoptosis will not take place, while it opposite happens when you give a surrogate LH in the form of SCG in the HMG injection. So does it matter whether we give HMG, SCG or give REC LH to these patients for LH supplementation? So what we are going to see is the duration of stimulation, the mean number of the oocytes, then implantation rate, and the clinical pregnancy rate. So when you are giving a fixed dose, recombinant FSH and LH, you find that though the duration and the mean number of oocytes are same in all the three groups, you find that the implantation rate is much more when you give recombinant LH in comparison to the patients who are given only HMG or in the patients who are given FSH plus HMG later on. And also, the clinical pregnancy rate is much more when you use a recombinant LH with FSH rather than giving the HMG, giving SCG as a surrogate LH, or again HMG to give a surrogate LH in the form of SCG. So RCD comparing the recombinant FSH and recombinant LH versus highly purified HMG, you find there are a higher number of oocyte retrieved in the recombinant LH group, and also 2/3 of the patients in the recombinant LH group would have more number of oocytes which can be frozen in comparison to the patients. So that means more oocytes, more good quality of embryos, more chances of freezing, and more chances of increased cumulative pregnancy rate. Though there are significant differences which exist between the LH and SCG at both the molecular and the functional level, but however, since at present there is a limited evidence which indicates that the choice of product containing LH activity impacts the IVF clinical outcome. So recombinant LH would be a better choice for LH supplementation rather than giving HMG or highly purified HMG to these patients to get better number of eggs, better implantation rate, and better pregnancy rate. Now, how to use a LH supplementation? In our center, what we do, we try to understand which categories the patient is based on the clinical features, age, ovarian volume, AMH and AFC count. And based upon that, the protocol patient. Now, AMH has come as a good ovarian response biomarker. And if you find that the cutoff values, if it is more than 2.1, will be high responders. And if it is 0.82 or low, it will be a poor responder. But however, you may have some surprises when even the high AMH, you'll get a poor response. And with the poor AMH value, you may get a better response. So that subgroups are different. We can discuss whenever it is required. So in our center, what is the preferred stimulation regime? In expected poor responders, we know that the patient is having a low AMH and the patient is elderly, and AMH and the antral count is also poor. So then in these patients, the stimulation is started from the day one of stimulation with the combination of FSH and LH in the 2:1 ratio, and the Antagonist Protocol is used, and which is added around 13 to 14 millimeter follicle size, and LH surge is given when the mean follicular diameter is more than 17 to 18 millimeter with the rec SCG 250 microgram. And which one is a better choice? The conventional protocol, that means a GnRH long protocol which we were using earlier with the rec FSH, or with the individualized control ovarian hyperstimulation with antagonist and the recombinant FSH and LH. So when we use, this is an expected poor responder, but after stimulation, you find that in a conventional stimulation protocol, you will observe 72% times poor response, while it will be lesser in the cases where the individualized control ovarian stimulation is given with antagonist and combination of FS and LH. The oocyte retrieved will be much more with the antagonist and recombinant LH. The cancellation rate will be less, and the pregnancy rate will be more in the patients where the poor responder, where the FSH LH combination has been given. Now the patients, as I mentioned earlier, also those who are more than 35 and those who are, hyper responders with the normal ovarian biomarkers, unexpected hyper responders. Now in these patients, the GnRH antagonist flexible protocol is used. Again, FSH and LH is given a 2:1 or to 3:1 ratio from the beginning only, and then once a follicle size is reached, then recombinant SCG is given to these patients. Now this patient is another patient. Like suppose the patient is more than 35 years with a diminished ovarian reserve, and recombinant LH and antagonist protocol, flexible protocol is the one which we are using it. And diminished ovarian reserve, again 2:1 to 3:1 ratio from the day 1 of the stimulation. But a patient who has got a normal reserve and who has shown good response initially 5 to 7 days, and the patient was on only recombinant FSH, in that the day 6 onwards we add recombinant LH 75 international unit along with the recombinant FSH. So that means you have not started from day 1 both FSH and LH, you have started added the LH once you find there is a slowing of growth of the follicles. So to conclude, adequate LH levels are critical for steroidogenesis to create an estrogenic environment which will help in the follicular development and oocyte maturation. And androgen secretory capacity decreases with ovarian aging, and androgen is important because that is a substrate for the estrogen production. And the mechanism includes decreased number of functional LH receptors and ovarian paracrine activity. And LH receptor polymorphism is involved in the hyper-responders, unexpected poor responders, where you need to give higher doses or longer doses of FSH in those patients. Again, I reiterate that you may have to add the LH to get a proper trajectory of growth. So the patients who could benefit from LH supplementation during the stimulation are the poor or the hyper-responders, or patients who are more than 35 years, or patients who are hyperhypergonadism. And what are the sources? Recombinant LH or the HMG. LH and HCG, they differ at a molecular and functional and clinical levels. So it would be better to use a recombinant LH rather than HMG. You'll get more mature, more M2 and oocytes, so more embryos to freeze subsequently. And individualized controlled ovarian stimulation with the antagonist protocol and recombinant LH is one of our strategies to maximize pregnancy in IVF, this group of patients. Thank you very much.
Thank you, sir, for such elaborate talk on LH. I think still little more confusion about LH. And we will definitely see the video on the YouTube, which Malti will upload, obviously, to understand what we missed again. So now I invite Dr. Sharda Jain ma'am to speak.
Can you hear me?
Ma'am, आवाज कम आ रही है थोड़ी.
I think, as far as LH is concerned, this is my weak area. And to be very frank, in my practice, myself and Dr. Jyoti have never used it. And that's why whenever people used to talk about it, I thought, it will be good to listen. And I think my fundamentals are clear today, when to use them and, the results can improve. I have absolutely no personal experience, and this is, I've heard many times, but I think today's talk by Dr. Brigadier Sharma has made me and Dr. Jyoti to think over that this is an area which you can definitely use.
But I just want to give 3 carry-home messages. Yes, LH is required in hyperhypergonadism. LH is required where you find that you are expecting a normal growth and the patient suddenly stops growing the follicles. You add LH that time rather than continuing increasing the dose of FSH. or when the woman is more than 35 years of age, and that is the time you would require giving the LH to these patients. Otherwise, most of the patients would do okay with the FSH only, because even with the downregulation with antagonist agonist, they have that much of LH level, which is just sufficient for the folliculogenesis.
No, but
Thank you,
what
sir.
we used to do till now, sometimes there has been a late, you come to know that the follicle is not growing. What we had been doing it, we were increasing the dose of whatever the gonadotropin was dosing it. But now I think you've told that LH will be probably better than increasing the dose of gonadotropins.
And that too, the recombinant will be better
Now,
rather than adding
Dr.
HMG.
I agree.
Dr.
Because
Jyoti
finding out
Agarwal, if you want to say something.
No, good afternoon, everyone. As Madam is saying, we have been using only HMG. But yes, definitely we are not instead of HMG, we should start using recombinant LH. And it will make a difference, I suppose, definitely. Sir, I just wanted to know, does LH supplementation or anything like it makes an impact in FET cycle when the patient is being prepared on HRT?
Yeah, the thing is, when the LH are very high, especially in the cases of PCOS patient, you find that the environment will be androgenic. So in those patients, when the LH is very high, you may have to downregulate it and then, prepare the endometrium rather than, just giving from day 2 onwards, you give the estrogens.
Okay.
I remember, when I was under training way back in 94 with Dr. Sadhana Sai Madam, she used to downregulate these patients, especially the PCOS patients and also the patients who are having, previous IVF and FET failure. She would downregulate them and then prepare the endometrium. The results were better.
Okay, sir. Thank you, sir. And one
Thank
more.
you, sir.
We have
So,
a-
I think I also don't have any experience of using recombinant LH, but one thing is definitely that sometimes in PCOS patients, especially if you start with the recombinant FSH, then if after, in between, in the later part of cycle, if you add LH, then you will get definitely good results. That much we are doing, but never used recombinant. So I think now we will have the panel discussion. And,
Dr.